My name is John Dymar. I'm a orthopedic spine surgeon at the Norton Leatherman Spine Center. I've been a senior staff physician there for almost 30 years. I have a particular interest for all those years in bone physiology and bone health, I think, which is critically important to the outcomes that we get with our surgical patients. And that has led us to the recent increased popularity in addressing bone health. And in my position, I have been tasked with really just familiarizing the Norton professionals as to the latest treatments, diagnosis, and just some of the physiology that goes behind our thinking about how to treat serious bone metabolism issues, most notably osteoporosis, which is by far the most common that we're going to see. So in my capacity at the Norton Leatherman Spine Center, where I also am a professor of orthopedic surgery at University of Louisville and also chief of pediatrics at University Hospital, a separate position. And I have really worked on this for quite a few years now, and we're setting up fracture liaison services, which really are there to treat people that have suffered fractures from having bad bone or problems with their bone health across the system gradually over the next several years in an effort to improve our care of these patients. Because when you have osteoporosis, it really requires lifelong treatment, similar to what we see with high blood pressure or diabetes or other chronic illnesses. And in many cases, it's been ignored. And a fractured hip can often lead to mortality, particularly in older patient populations, which is why we're making an effort to make a series of CME qualified lectures to talk about bone health. And we're going to start a series of these, probably have 5 or 6 lectures with myself and other people from the Spine Center and perhaps also from the orthopedic side, and talk to you about what you can do and how to screen your patients and how to really treat them as far as medications, because the real place we need to address this is in our primary care health providers, whether you're a primary care internal medicine doctor, family doctor, a nurse practitioner, one of our PAs, all of you that take care of patients, particularly in the older population, should be screening and try to actively treat this and be familiar with it. So we're going to have a system-wide effort to train everybody, and part of my goal, of course, is to create some CME content so you can get 2 credits out of this, and that's what I'm here to do today. And so my lecture today basically is going to deal with diagnosis of osteoporosis. When you look at bone health, you're really dealing with a metabolic bone disease. And I really like you to put your Sherlock Holmes hat on and think about what you're looking at and go a little bit further as far as diagnosis and laboratory testing that we'll go through, and particularly how you do this with radiographic testing, which is really quite simple to order. And we have multiple ways we can arrive to the diagnosis of osteoporosis and get these people started on the required treatment that they need to prevent further fractures. So medicine is really about being Sherlock Holmes, I've always felt, and it's diagnostic challenges and thinking about things and not necessarily just ordering tests in a hellish killer fashion, but working with an algorithm that you come to a successful diagnosis. So we're going to talk about diagnostic testing for osteopenia and osteoporosis. Remember that after the age of 30, you start to lose bone mass for the rest of your life. You can slow the loss by exercise and perhaps taking vitamin D and healthy lifestyle, don't smoke or drink, but inevitably you're going to lose bone the rest of your life because the progenitor cells within your bone marrow start to diminish, and they're responsible for making new bone. If you assume that everybody remodels their skeleton once every 10 years, you'll find that you have about 5 or 6 cycles of remodeling, and those cycles get longer and less successful as you get older. So by the time you're 65, many women should be screened for osteoporosis for sure, and certainly men by age 70. Keep in mind that although osteoporosis is usually joined at the hip with women, about 20% of men over the age of 70 will have significant osteoporosis, so it's not just a female disease. And not to mention the fact that there's a lot of causes of it, such as dietary problems, excessive smoking, drinking, and in men particularly low testosterone. So these are some of the features we're going to look at in diagnostic testing. Now, consideration of the aging spine. We all get degenerative disc disease, spondylosis, and spinal stenosis as we get older. Most of us will not have symptoms throughout our lives that we need anything surgically done, for example, but some of us do. As this happens, as you notice, you'll get shorter, you'll get more postural problems where you'll lean forward further, Your spine, in the upper spine, you develop kyphosis, more round back. Your lumbar spine will inevitably collapse and start to lose lordosis, which leads to basically leaning forward as you get older, which is a classic posturing associated with more elderly patients. You can do a lot to prevent this by keeping your bone strong, because a lot of times if you get a fracture of your spine, for example, this will progress much more rapidly and it will lead to disability and a lot of problems. So we also develop a lot of lower extremity arthritis or knees and hips that also will affect our posture and will also affect the ability to compensate for these changes that inevitably will happen in our spine as far as developing a round back or kyphotic deformity. So we want to look at particularly osteoporosis and osteomalacia, and we'll talk about what those terms mean. As you can see below, this is what happens when we are a spine surgeon. We develop our minds and then eventually end up leaning over patients our whole life and develop a round back posturing. So why is bone health so important? Well, osteoporosis is a worldwide epidemic. It's present all around the world. Many people don't live long enough for it to become clinically important because the average life expectancy now for a man and a woman is over 80. But in 1900, the average man lived to be 46 and the average woman lived to be 47. So you can see that you probably died of measles or mumps or whooping cough when you were young, or tuberculosis in middle age, or from soot in the factory you worked at. But the bottom line is that people live a lot longer now, and we essentially can outlive our skeletons. And so we see more of this now because of the aging of the population. There's inadequate treatment and delivery of care. This is not screened by many primary care providers. It just wasn't taught to us very well, unless you're an orthopedist, of course, in medical school, and so it's often off our radar. So there's just not good identification of it. There's very poor treatment guidelines and patient compliance until the last 5 years, and we have made a concerted effort to make national guidelines, particularly in surgery, of who should be treated, because if we don't treat the osteoporosis with orthopedic and or spine surgery, we have catastrophic results and failures. The lack of government insurance and support, as you have all experienced trying to get some of the newer medications approved because they are costly, is very difficult, and this results in a very slow delivery and ability to use some of the medicines that are really effective to increase bone density, particularly what we call the anabolics. Osteoporosis directly affects our outcomes, as I mentioned earlier, and this is why I'm very focused on this, along with a lot of my partners in the Leatherman Spine Center. And there have been many of the societies, including the American Orthopedic Association, that have really tried to push this among our members to try to get the orthopedic surgeons, at least, to be somewhat the disciples of good bone health and disseminate this to the rest of the healthcare population. And it has really become much more seriously looked at over the last decade, fortunately. So elderly are the most rapid growing segment of our population. By 2030, 1 in 5 individuals will be over 65. That's the baby boomer generation, of which I'm part of. And it's only going to get worse until after we get a diminishing of this centralized population. And as you can see on the left there, you can see some incredible deformity of the spine when the bone gets so soft, it can't even support us against the weight of gravity, and you buckle your sternum and get a lot of fractures. So keep in mind, we're dealing with a population that is going to have this specific diagnosis. So when we talk about osteoporosis, osteoporosis is a bony condition defined as a decrease in bone quantity and density and mass. In other words, it's not as strong as it used to be. The architecture of the spine loses its cross-linking I-beam, so to speak, and it will literally fracture under just normal weight bearing or rolling over in bed. Osteomalacia is a little bit more specific in that it looks at decrease in bone quality. Okay, and this basically is like for an alcoholic or somebody with liver disease. The collagen that makes up the bone becomes poorly organized, it doesn't get ossified, and you get more flexible collapsing bone. Often with people's lifestyles, these exist simultaneously. So keep in mind, osteoporosis is a decrease in bone quantity. All right, so really what happens when you look at it is you have normal tuberculi on the left that are very dense and interconnecting with spicules of bone, but they get hollowed out essentially as you lose calcium and you lose the collagen matrix that makes the bone. And so really what happens is it gets so weak that it'll just collapse with normal daily activity. And one of the key things you'll notice that will diagnose osteoporosis, if somebody falls from height and fractures a radius or a hip, they almost certainly have osteoporosis, because a person with normal bone would be bruised but wouldn't suffer that. So your whole life, Okay, bone contingency remodels, as I mentioned earlier. And any imbalance of this, from liver disease or kidney disease, also can develop osteoporosis. So people that have bad livers, for example, don't really hydroxylate vitamin D2 to D3, which is the essential component that you take over the counter that helps your bone stay strong. And so what happens is you end up basically having less bone production and more bone loss, and that will result in you getting a weak skeleton and some of these osteoporotic fractures. On the right, you'll notice that these are some of the recommended daily doses and intake of calcium, and you can see it varies from person to person. For example, female athletes will need more calcium. Young adolescents need more calcium in their diet. Pregnant and nursing women need more calcium. It's only common sense, but these are tables that are widely disseminated, or you can go back to this lecture and look at them and decide how much you want to give an average person. Most people recommend 1,200 milligrams of citracal, which we'll repeat many times through many lectures, because that's 1.2 grams, and that's what an average dose would be for most people as they get older. So there's a lot of non-pharmacological treatments of osteoporosis, none of which will really reverse the effects of it. They'll slow down bone loss, but they will not build bone. And that's really important to remember, because a lot of people are under the impression that I take some calcium, some vitamin D, I go to a spinning class 3 times a week, and I won't have bone loss. A lot of the development of osteoporosis is genetic. It's based on the COLA1 and 2 genes that produce collagen, and it will run in families. And the prototypical person, of course, will be a Northern European white woman that smokes 2 packs of cigarettes a day and drinks about 3 shots of bourbon a day. And so there's a lot to be said about lifestyle and looking for causative factors that cause us to develop osteoporosis. So generally we recommend as a baseline taking some citracal, vitamin D3, not D2. You can buy D2 in the drugstore. You don't want that. You want D3, the active metabolite, anywhere from 2,000 to 5,000 units a day, up to 50,000 if you want to take it a week. Low impact aerobic exercise such as water aerobics, bicycles and things along that line. You should absolutely stop smoking. It's a definite risk factor. You should stop drinking excessively, keep it at a minimum. And in older patients, you should always be cognizant to tell them to be careful with falls. Is this enough to increase bone mass and to decrease osteoporotic fracture? No. It'll slow the progression of bone loss and the development of severe osteoporosis, but it will not reverse it. That's only for medications. The identification of risk factors, you can kind of look quickly through this. It only makes sense that it's going to be smoking and vitamin D deficiency. Hyperparathyroidism is very common. Often people have adenomas. Inflammatory bowel disease, inflammatory arthritis. Why? Because they're put on steroids, or they're put on the new tumor necrosis factors that also affect your tissue. Celiac disease affects D3 absorption, renal disease, autoimmune disease, alcohol abuse. Any of these things that are present and you suffer an acute low energy hip fracture, vertebral fracture, or wrist fracture just from standing, there's a pretty good it's a pretty good chance you're going to have osteoporosis. It's pathognomonic for it. Consider ordering these laboratory tests, okay? This is what we have in our standard panel. It's actually an order set within Epic, and we will order all these tests on somebody that's been diagnosed as probable osteoporosis from a fall or a fracture or a vertebral fracture in our office. And you particularly want to look at the vitamin D3, the PTH, testosterone, and over the last 2 years since we've been using this, we probably have found 5 or 6 people that have multiple myeloma from doing our serum protein electrophoresis. So you're going to pick up a lot of underlying things that will cause metabolic bone disease, specifically osteoporosis. The classic cause of rictus is dietary, okay? On the left is a good thing to look at about all the wonderful foods you can eat, such as cod liver oil, egg yolks, or fresh shiitake mushrooms, and how much vitamin D they have per unit. And the bottom line with this is you got to eat a lot of salmon, or you have to eat drink a lot of cod liver oil, which if you've ever tried it is probably one of the worst things you can take, to get up to that 2,000 unit level. Now, remember 2,000 is really given in people, not normal people, not middle-aged people, but people that have osteopenia in particular. Those are the people that you might want to give it to, because there's a study we'll look at that says it's not helpful in normal people. When you look on the right here, these are where the vitamin D levels are critically low, that we call less than 20 nanograms per milliliter. Mothers, okay, Caucasian females, 9 to 11, and we'll talk about that. Afro-American females, Afro-American children, they are affected with it, even though their bone tends to be generally more dense. Hispanic children, you can see that children worldwide, this is a real epidemic, and that's going to lead to what we had classically seen a century ago, rickets, okay, and deformity in the bones. So when you look at this study, this was published by Cummings. What I just alluded to is normal people don't need vitamin D. They go into a big elaborate study about this. This is a massive study where they looked at 2,500 people, men and women, age 50 and 55. Well, that's when osteoporosis really takes off and accelerates exponentially. But they said that really you should stop screening at those ages, and they don't recommend vitamin D supplements because it really doesn't do much at that age or prevent fractures. So keep that in mind. Now, there's 3 ways that you're going to be able to make the diagnosis of osteoporosis. A previous fragility fracture, what we talked about, a fall from height, and frac scoring, which is a very simple form you can download that's available online that if they haven't filled it out, if they have anything positive on theirs, they've got osteoporosis, and you can proceed with treatment just based on that with the insurance company. That's really important. The next thing would be a DEXA scan, either DEXA or DXA is more commonly used now, and that will tell you the actual bone density compared to a 30-year-old, the T-scores that you're all familiar with. And what we use a lot are optimistic Hounsfield units from CT scans, because we can measure a regional unit that I'll show you how to do, that you can actually determine it based on that. So routine screening without risk factors should be in men at age 70 and women at age 65. If you have any suspicion, early hysterectomies, loss of estrogen in the early 40s or will cause this, or people that use excessive amounts of alcohol or smokers, well, you can bypass those recommendations and get a DEXA scan earlier. And you should get them every 2 years after, because they can change rather dramatically in a couple of years. Something to keep in mind. Here's the Frax tool. It's very simple. You can see on the right here. You just fill it out with the age, and you look at all these basic risk factors when you smoke, if you're taking steroids, rheumatoid arthritis. All these things will key you to the fact that they're going to have poor bone health. Okay, and it will calculate the 10-year probability of you having your patient have a fracture from one of these risk factors. Okay, any fracture is pathognomonic of osteoporosis from height. So keep that in mind, and that is captured in this Frax osteoporosis tool, which is available. Okay, it's in many languages too, including Spanish. Now, when we look at radiographic tools for the assessment of bone quality, we're basically going to look at DEXA, DEXA or DXA, CT scanning, and MRI, and we're really just going to talk about the first 2. So DEXA is the gold standard. Okay, it uses 2 beams that differentially will tell you the density of the bone. It's the gold standard. It's very, very, very low radiation, 0.1 to 0.5 millisieverts, which is really, you're allowed up to 3 millisieverts a year, or 5 millisieverts a year if you're a nuclear power plant worker. So you're well below that, because keep in mind, people are getting massive amounts of radiation with medical testing nowadays. CAT scans are ordered at a drop of a hat. And if you ever wonder, why there might be increased cancer rates, this may be just one possible cause. It uses a T-score and a Z-score. A Z-score is comparing your bone to an age-matched peer. So that's what you use in children or 18-year-old. You compare it to another 18-year-old. And if it's low, okay, well, you probably got a problem, some sort of endocrine problem, vitamin D deficiency, and we'll show you a couple examples of children that come in. Children will naturally become osteopenic between the ages of 9 and 11 as they go through their adolescent, pre-adolescent growth spurt, maybe why they get scoliosis, we think, and then they'll get back to normal bone health by the time they're 16. So there are some periods during growth that you may actually experience some osteopenia, not osteoporosis, in children. Now, the Z-score is a BMD, bone mineral density, compared to age-matched peers. In other words, the T-score, where you go back, and if you're 40, you're going to compare it to the standard, which is a 30-year-old adult. Remember how I told you start losing bone mass at that age? That's why we compare it to that. So a T-score at age 50 will be compared to a 30-year-old's bone density, and at age 60 the same. So you can see that's why you see the diminishing scores, if that makes sense. Now, this is a typical nomogram you're going to get. You can see that anything less than 2.5, like 0.5 or 0.1 to minus 2.4, is basically osteopenia. You're on the way to osteoporosis. Now, this is split up into 2 distinct little compartments, but that's not how it works. You have diminishing bone strength all the way along this curvature, all the way along this nomogram. In other words, so a minus 2.0 is not normal bone. So although you might not get a fracture from height, you might get it from standing on a stool 3 feet tall because your bone's not going to be as strong. So think of it as a continuum, and that minus 2.5 is what we've elected with the World Health Organization, essentially, to decide that's where we're going to start treating with medications. Okay? But if you have a lot of risk factors above, we might treat somebody sooner, for example, if they're going to need a major surgery where their bone is already so weak that the instrumentation will pull out or it won't hold when we fix a fracture. So it's a continuum. Minus 2.5 is when osteoporosis starts, and that's what you really need to know. Now this is an example of what they read out, and then we base it, the number one place we look is the femur, not the spine. Okay, and the second place is the spine, and the third place, or the least accurate, is the wrist, because all three of those things will be looked at under this testing. Now keep in mind that if you have a total hip, it won't work. So then we have to basically default to looking at the spine to find out what's going on. But here, look at the T-scores in the middle here. You can actually see they're 1.5, 1.4, 1.2. Well, this is a 65-year-old person, and you can see why this is genetic and based on also lifestyle. They may come in with great bone. That would be better than a 30-year-old that drinks, a fifth of whiskey a day, okay? So that's why we look at this thing, and this is just an unusual patient. And as long as they have this kind of bone, it's going to take something like a fall from a roof or an auto accident to really get a fracture because their bone's going to be that strong. That's how useful this testing is. And you see in the middle there, the T-score is 1.5, pretty much for about everything in the hip. Now, diagnosis based on DEXA scores, the T-score is a standard reference. So if you look at the scale on the right, this is universally accepted. A T-score of -1 and up is normal. Not quite normal, but you can think that in your mind. -1 to -2.5 is osteopenia, like we just talked about, and anything greater than -2.5, they've got osteoporosis and really should be treated, particularly if they're below that 65 and 70-year-old threshold we talked about. If they've had a fracture and their T-score is -2.5 or greater, they've got severe osteoporosis, and they will need very aggressive treatment because they're going to get a fracture of the other hip if they just roll over in bed, or a fracture of their spine. So you have to understand that between -1 and -2.5, 50% of the vertebral fractures occur in that range. So as I said, think of it as a continuum. That's how we do in the spine, is that if we see fractures and it's -2.0, we're probably going to treat that because there's other things that happen in the spine that we'll talk about with the next test, okay? When you look at the distribution of the BMD by bone score, as you can see here, that basically the older you get, the more likely you're going to have a fracture. And the worse the bone is, in particular, as the bone density gets worse and worse and worse, you can see that the fractures in men and women toward the center of the scale there increase. So the bone mineral distribution for most people is in the middle, and you can see women with fractures, it starts just toward the peak of the curve that you see, and it goes up and up and up, as does men as we get older. And the fracture rate, as the T-score gets down to -3.5, is really quite astronomically high. Now, this is another way to look at a fracture rate. Approximately doubles with every standard deviation. So when you go from 1 to 2, -2 to -3, -2 to -4, the fracture will double with each one of those, the risk of getting a fracture. So these are real numbers that we've looked at over the last couple of decades, so we know what's going to happen if this goes untreated. The other test you can do at the same time that you get a DEXA score is a trabecular bone score. Now, why is this important? We have found, like I said, that half the vertebral fractures occur in the osteopenic range. And something's happening inside the interior of that vertebrae that the DEXA can't see because there's spurs and other such things around it that give us a false reading. So this looks inside the vertebrae at the actual trabeculi, the bone support between each one of the end plates of the vertebrae, and it will detect if that's degrading and if you're likely to get a fracture. And it's very nice. It's paid for by Medicare because they recognize the importance of it. So you order both at once. I highly recommend you do that. We have that available currently downtown Norton's, so you may have to send them down there. But if you're have somebody that has a T-score that's -1.5 and they've got a vertebral fracture, it's worth ordering this to see what's going on inside the vertebrae, because you may have regional differences. The hip may be stronger than the spine and vice versa. So you may have to look more and put everything together as Sherlock Holmes would to come up with a better diagnosis, and not just say absolutely I'll use the T-scores out of the DEXA or vice versa with the CT-HU units that we're going to talk about. Okay? And it's got nice grading, as you can see here. Women drop off more quickly as they get older than men. Men tend to stabilize. That's why we have less vertebral fractures than women do, because as you can see, men kind of stabilize out on the blue line there. And Norton's will give you this beautiful little nomogram here that's just much like the DEXA scan that'll have that little box on the right there that'll tell you that you're in a good zone and you've got decent enough bone that you won't have a problem with a vertebral fracture, that it's strong enough. And then you can actually look at every single one of those vertebrae, and it will give you the T-scores and also the Z-scores. And you can really, it'll give you a scaling of what the chances are that you're going to get a fracture when you're in the osteopenic zone too, not just osteoporotic. So that's something to keep in mind. Another thing we quickly can do with the DEXA scanner, we actually can do a vertebral fracture assessment. It'll use a low beam density that's a lot lower than a CAT scan or regular x-rays, and you'll be able to identify a fracture. And we don't do this that often. There is a little bit of a benefit to it because we save radiation, but the resolution isn't as good. It's really just for us as surgeons to really have the detail that we need. It just tells us we got a fracture, okay? So that's pretty much the stuff that's done with the DEXA TBS. Now the third assessment of how you can diagnose this is a CT assessment of bone density by using what's called Hounslow units, and we'll go over those. You can use just any x-ray, any CT scan you have, an abdominal CT, a pelvic CT. You can read it right off it by using the annotation window, because the CT uses pixels for every portion of the spine and abdomen, and it'll look at the density within those tissues, and it'll basically reconstruct the image, whether it's the kidney or the lungs where there's a lot of air, or the bones where they're more dense. And it will often identify occult fractures that you can't see with regular x-rays and other such things. So if the patient has a CT scan, which we almost always do when we're planning surgery, we will automatically be able, on about 90% of the people I think we see in our office, tell you right away if they've got osteoporosis, and we'll proceed to get a back order, a DEXA TBS score if it wasn't done, and notify somebody to treat the bone density. So this is an attenuation coefficient, each voxel or spot that it looks at, and you'll be able to actually measure the density of the bone. You see the 151, that's slightly osteopenic. Okay, you can obtain it from all the CTs, and you do what we call the region of interest off a menu. I'm going to show you how to do that so you can do it yourself, okay? And it will actually estimate the bone density, just like radiologists can look at the kidney and look at the Hounslow units and have a high suspicion that something growing there is in fact a renal cell carcinoma. We can do that with the bone for bone density. What's great about it is a lot of people get screening CT scans, and there are people developing AI that will look at those and tell you off a CT scan for like an abdominal problem. It will also simultaneously look at the vertebrae and tell you whether or not you got osteoporosis. So those things are coming that you may get a notice that says, oh, by the way, yeah, the patient had a ruptured ulcer, okay, in free air, but oh, he also has really severe osteoporosis. So those are things that are being developed as we speak now. So Hounslow units. As I told you before, air is 908, cortical bone's 1,000, cancellous bone is 106. That's osteopenic, right? A little bit between 160, and the threshold for osteoporotic, by the way, is about 120 in that area. So he's already osteoporotic. And of course, muscle and et cetera, they all have different readings with this. So what happens is when we start to look at the Hounslow units, not unexpectedly, as you get older, depending on your gender, they go down because you're getting thinner bone, you're getting osteopenia, and then eventually osteoporosis. So you can see that the men are pretty good till we're about 60, and then we catch up with the women by the time we're 70 or 80. So there's a linear decrease in age in the Hounslow units as the bone gets less dense. Okay? So if you know ever wondered what PACS means, and we use it every day, that word, picture archiving, and communication system, the PACS system. Okay? And we're going to measure on that. We can measure the center of the vertebrae, and we can determine, or the center of the hip, determine what the bone density is, the Hounslow units. So here's how you do it. Okay, you pull down the menu, right? You're all familiar with this, and you find annotate. Okay? Then you go over and you find the elliptical ROI, and you put it on an axial image of the spine, and you just draw a circle till you're within 3 or 4 millimeters, and that will tell you what the Hounslow units are. There's 67 here, right? That means they're going to be profoundly osteoporotic, most likely, when we back check it on a DEXA scan. Okay? Very simple to do. Annotate elliptical ROI. You should be able to do this on every CAT scan you have. You can blow up the spine, do an axial view on it, and you can check it real quickly if you want to do it. It's a surrogate way to do a DEXA scan and identify osteoporosis. So basically you place a centroid in the middle, sagittally and axially, okay, like you see here. Okay, myelographic dye will actually, some people feel it doesn't make any difference. Other people think it raises it a little bit artificially, about 10 points. Okay, and you can see that you want to do it with an axial view, not the sagittal view, okay, because there's about a 10 to 15 point difference. So we prefer the axial view. That's what you want to do, is the one on the right. Okay, and HU reliability, it's very good. It's 95% from doctor to doctor, as you see here. You can see we measured it within multiple close levels here, 109, 99. So we're pretty good from doctor to doctor in reliably reproducing this. IV contrast, we'll raise it about 10 points. Some people think, some others think none, and we'll show you that in a minute. Small differences among scanners and other such things, but really no difference. From machine to machine, you're going to be within 10 points of it and everything. We followed up with another article, and we found that the MRI dye did not make any difference. But just keep in mind it may with about 10 points if you measure it by looking on some other test and everything. So these are the numbers I want you to remember, okay? Osteoporosis, most people think that anywhere from 100 to 120, 110 to 120 is frank osteoporosis as far as the Hounsfield unit. Remember the T-score is minus 2.5. With this one, it's about 110. Okay, for osteopenia, it's between 135 and 150. And normal bone density generally is felt to be greater than 150, but most people think it's actually up to 160. So keep those numbers in mind. If your Hounsfield units are less than 120, they're probably osteoporotic. Between there and 160, they're osteopenic, and above, they're probably got normal bone. And so you can see, look at this. 203 excludes osteoporosis for sure. 160 is the threshold for you're going to go into osteopenia. That continues all the way down to when you get to 110, when that's the threshold for being frankly osteoporotic, which continues all the way down to 50. Now you may think 50, how do they get all the way down to 50? I see people that their Hounsfield units are basically 10. Okay, and they are at risk of getting a fracture just picking up a stick of gum off the floor. And so that's why it's important to kind of know the spectrum of this, and that osteoporosis is less than 110 and osteopenia less than 150. Generally accepted measurements on these Hounsfield units. A very useful tool. Now, can you convert them? Yes, of course you can. So basically, 195 is good bone as far as the Hounsfield units. Okay, if you get down to 118, okay, on the DEXA, on the Hounsfield units, that's going to be osteoporotic. And anything down below 97 basically is going to be, frankly, osteoporotic. So it's a good thing. So remember, any Hounsfield units less than 50, they are in dire straits. There's a good likelihood with the most minor injury or even rolling over in bed, they won't be able to resist the pull of gravity. Okay, they're really going to turn into cuttlefish or octopuses that not have any significant spinal support. That 50 is really a severe threshold of spontaneous fractures, and we will never do surgery on those patients unless we go through 6 months to a year of treatment with an anabolic medication to build their bone up, because it will abysmally fail. So 50 is a board question for us, by the way. So anyway, age-related changes in Hounsfield units. As you expect, here's another thing that shows a linear decrease with age. We might have had that in there before. We look at normal bone density. Here's something that we looked at in children, myself and Dr. Kosi Nagata, who was one of the attendings in Japan, who spent a year with us doing research and fellowship with us for spine training. And what we found was, amazingly, remember I mentioned earlier that kids get this? Well, sure enough, when we started measuring them, just like we do adults here, we had a whole bunch of x-rays over there that had been taken for trauma, and we just went over and looked at them and checked their bone density retrospectively. And what we found was, you can see in the middle here, when they get to be 8 or 9, they actually get into a osteopenic range, and it drops off, and then it comes back to normal. And so children can get osteopenia and frank osteoporosis, particularly if they're vitamin D deficient or have fad diets. We see a lot of kids that for some reason like to eat Doritos. I'm not sure why, called the Dorito diet. But they basically not only do not have B2 because it's corn, but they end up getting osteoporosis. And so here's an example real quick, just to break the monotony of slides. 17-year-old female comes in with a severe auto accident. Here's her car, obviously pretty severe. It crushed in the front, and the airbags went off all over the place. And she comes in with just tremendous back pain. And when we look at her, basically she's got a fracture at L1, L2, and L5, and they're severe fractures. But when you start to look at her bone, it looks kind of funny. You look at all these fractures. These are pretty severe fractures. Kids tend to get multiple fractures. They dissipate the energy, but there's more going on there. And here's her CAT scan. You can see they are frank burst fractures. They're crushed. It means your bone most likely is something going on with it. Usually you'll just get compression fractures without all that bone getting shoved back into the spinal canal, which in kids will remodel. You don't have to operate on them. And so why did she suffer all these fractures? So I told the spine fellows, hey, let's check out her bone density and stuff. And so we just went back to the CAT scan, and here you are. Her HUs, right, are 86, with anything less than 110 being osteoporosis. So here we got a kid that's got it. Okay, well, it turned out that what she had was low vitamin D. She, for whatever reason, was vitamin D deficient. In modern Louisville, Kentucky, she basically was vitamin D deficient like they used to be in factories in Europe at the turn of the century with child labor, where they all got rickets and everything. So we went ahead and we started on high-dose vitamin D with the help of our endocrinology friends. And when we first asked them, they said, oh, kids don't get this. But in fact, this child did, and she did great. Okay, so basically we put her in her brace, and here she is. She held up just good. And we put her on vitamin D, and she altered her dietary intake, and she did great. So keep in mind that these are things that we want to talk about. So comparison of DEXAs versus optimistic. The bottom line is they're very comparable. Okay, you can use either one of them. When you look at CT correlation with the data, the results are very, very similar as far as reading true osteoporosis. They're not going to be 100%. That's why you may need both of them. So all these articles show that they're very compatible. You can use either one of them. Here's one where we looked at bone strength of the lumbar vertebrae and everything, and they found that the BMD and HUs both, two different tests, okay, there was no difference in how they read it. And prediction of vertebral fractures, they both will predict vertebral fractures. And the CT in particular, the Hounslow units, once you get below 90, 97, your risk of getting a vertebral fracture goes way up, as you can see here. So there's three other methods that we'll just talk about briefly, and then we'll take a break. The modality, there's biomechanical CT testing, which is modeling with a computer, with the CT scanner. There's quantitative CT, which is very popular, has been around for a long period of time. The problem with that is, at least traditionally, it had a much higher radiation exposure than doing just a simple DEXA scan. An average abdominal pelvic CT has between 5 and 6 millisieverts of radiation. Well, that's more than your yearly dose as a nuclear power plant worker. So when you order 5 or 6 CTs, that's 30 or 40 millisieverts. That's a lot of radiation. You know, you get to 50 millisieverts and your hair will fall out, particularly in one dose. So you got to be careful with these. And of course, MRI, we have some MRI ways we can do it, but they're less than successful at this point. So the FEA modeling, the biomechanical assessment, we basically can do a CT, and we can model out of it, and through a computer analysis, we basically can come up with a lower dose, effective way to look at whether or not you're at risk for having osteoporosis and a fracture. You can see it's fairly compatible. The correlation between the BCT and the DEXA was similar in the center. Okay, the correlation in the left and right hip was similar on the bottom graph, you can see. So it will actually pretty much mimic or be another way you can do bone assessment and to see if they've got osteoporosis. We do not have that available here. We just don't really use it that much. We just use the two tests we have. The quantitative CT is another way you can do it, where it looks at the bone that I mentioned earlier. We have the biomechanical and, of course, quantitative. Again, it's a traditional CT scan, and what we do is we have phantoms that we can compare what the bone looks like to known CT readings, and it'll give you a Hounslow unit to tell you whether or not you have osteoporosis. The problem with it is, again, it's more X-ray exposure, and we tend not to do that here at Norton's Hospital much anymore. The vertebral bone quality index is done on the MRI. The bottom line is, the more osteoporotic the bone is, the more open the marrow cavity is. There's less cross-linking of the tuberculi, and so there's more fat. Because remember, in your extremities in particular, there's not a lot of bone marrow anymore. It's filled with fat. And so you can measure that fat signal, and basically you can determine whether or not you have osteoporosis. So if the fat goes up, signal intensity goes up, and the MRI can measure that in certain instances and tell you if you have osteoporosis. It has been looked at extensively. Most of the people I talk to that are experts at some of the bigger centers that have invested in this model really don't use it that much, at least the orthopedic surgeons, because it doesn't seem to be that reliable. So it's just a program that you often can put in your computer, but I can tell you now that when we put the tubercular bone score program into our DEXA scan, it is not an insignificant investment. And so you have to remember that, and they've looked at it in various studies and everything, and it's only a moderate correlation to the DEXA T-score. Okay, and so that's why most people don't use it. So we'll stop there just for a second. Everybody take a breath, and we'll be back in a minute, and we'll go over some questions that we're going to talk about that will be good for CME, just to kind of refresh your memory. All right, we're back. We're going to do some CME questions. You can take these individually, but they're questions designed to be instructive and to answer hopefully some questions you have, and also to point out some really important things that I think are important to know about osteoporosis, and we're going to talk in the future, of course, about treatment next, And also we'll talk about bone physiology for those of you who are really hardcore and want to get down into the nitty-gritty. But these are really just directed at diagnosis now and the various 3 identification things we've talked about and how to do ROI and things, which I think you should really learn. You can go back and look at this lecture and learn how to do it. And all the CAT scans you have, you can just blow them up on the axial views, get in the middle of the vertebrae on both the sagittal and axial views, and you can measure the HUs. And if they're low, then they probably got osteoporosis. And it's easy to do. I can tell you that all of my nurse practitioners do this on a regular basis, bless their hearts, and identify this. And so we have people that have all been trained with this, and we have 9 nurse practitioners, probably more, spread across central Kentucky. And so it's something that's easily learnable and a very quick way. And if you find something where it's exceptionally low, you can go ahead and back order a DEXA TBS score. So the first question, what is the definition of osteoporosis? Is it a decrease in bone quality due to poor quality collagen component of bone? Is it a decrease in bone quantity, the amount of bone there, and mass density resulting in decreased strength? Is it microfracturing of the bone? Or is it increased density of the bone as a result of too much calcium deposition? So the answer is B. Osteoporosis is a decrease in bone quantity. Osteomalacia is due to poor collagen and hence poor ossification, resulting in poor bone quality. Microfracturing of the bone is a component, a lot of times, of osteoporosis, because have you ever wondered why you'll have somebody 70 come in and say, you know, I had this really bad back pain for two or 3 weeks, but now it's all gone? Well, a lot of those people may be suffering little small 2-5% end plate fractures that heal very quickly, and you may not even be able to see them on a regular x-ray without getting a CAT scan, and then they'll heal them. And then they'll go along for another 3 months and they'll get another fracture. So microfracturing is probably, a lot of people feel, a component of osteoporosis, because you'll see people come in with kyphosis and not have really had a severe accident or a bad fracture. So that's the answer to question number 1. Now question number 2, what 3 methods are available to diagnose osteoporosis? You should have these cold, okay? A, DEXA TBS. B, I'm not sure why that's underlined. It's of no consequence, though, the answer. B, a CT scan region of interest, ROI, annotation measurement. C, a bone scan. D, fracture scoring assessment. And your choices are either one of those, or E, A, B, and D, or F, B, C, and D. Answer is E, DEXA TBS, CT scan, and fracture scoring. All 3 of those are accepted methods to diagnose osteoporosis. And the fracture score is great because if they've had a fracture, or if they have any of those risk factors, the insurance company will accept that as the key diagnosis or method of diagnosing osteoporosis, and you'll be allowed to treat. Now, you may not be able to treat with an antibiotic, and they're going to probably require a Hounsfield unit and or a DEXA score, but it'll at least get you started on some of the catabolic ones, medications such as bisphosphonates, that we'll talk about in the treatment section. Question 3, what CT Hounsfield measurement is an absolute counterindication to an elective spine surgery? Well, this one's easy because I made a big deal about it. It's D. Anything below 50, those patients are subject to getting catastrophic fractures with activities of daily living, such as rolling over in bed, sitting down on the commode, or just a simple fall. Or quite often they'll just pick up something that's not very heavy, 10 pounds, and they'll end up getting a fracture of their spine in particular. So 50 is the absolute threshold. So if you see something below that, they need really emergent treatment to prevent a pathological, potentially fatal fracture. Question 4, children may present with osteoporotic fractures due to poor bone quality. Is that true or false? Well, I showed you a case to alert you to the fact that you need to be aware that particularly the pediatricians and the nurse practitioners that take care of children is, yes, they can get osteoporosis. And it's not terribly uncommon. We see that dip in adolescents in the scoliosis patients where they get mild osteopenia that we think might have something to do with scoliosis. But nonetheless, the answer is true. During adolescence, children commonly develop osteopenia and may develop frank osteoporosis due to a wide variety of conditions, including vitamin D deficiency, even in the United States, as we saw. Question 5, a fall from height that results in a fracture of the wrist, hip, or spine is pathognomonic, highly suspicious, for underlying osteoporosis. Is that true or false? Clearly true. Okay, as we talked about, a person with a spontaneous fracture of the vertebrae or hip fracture from the standing position is going to have osteoporosis. So we're going to conclude this session of diagnosing and the methods you can do to diagnose osteopenia, osteoporosis. And it doesn't just look at those two diagnoses. It also looks at bone metabolism in general, because later in our course series, we're going to show you some cases of things that can cause what appear to be spontaneous vertebral fractures in particular, or other fractures elsewhere in the body, that are caused by other types of metabolic bone disease, okay? For example, you can have sickle cell anemia that will enlarge the marrow cavities that will result in spontaneous vertebral fractures, okay? Or you can have cancer in the vertebrae that's undiagnosed, like myeloma in particular, which is the most common primary bone tumor within the marrow space of the vertebrae over the age of 50 that may cause a fracture. And a lot of times they'll be written off as just a compression fracture, and they won't even have their osteoporosis treated, let alone look, which is why we included the serum protein electrophoresis in our series of lab tests in our panel that you can order through Epic. So we'll talk about all those things. But what I want to highlight from this is, remember the three testing modalities you can use. You can use the DEXA with the trabecular bone score. It's really probably best to get those together. You can use any CT scan you have and look at the axial view using the ROI methodology I showed you to get an idea of what the Hounsfield units are. And anything over 120, 130 is considered basically fairly good bone. Anything below 120 is osteoporotic, particularly below 100. Okay, so if you get a reading of less than 100, okay, particularly if it goes down toward 50, then you have frank osteoporosis. And anything between 110 to probably about 130 or 40 is osteopenic. You're on the way to osteoporosis most likely. And anything above 160 is probably pretty good bone, particularly if you're in your 60s or 70s. Okay, so those are the two primary methods. And the other thing, of course, is just download some of those FRAC scores, or we can get those to you, that you can keep in your office and have your patients fill them out, particularly women over 65 and men over 70, okay? And just simply see if they've had any of those risk factors, which may allow you to proceed to more testing with the radiological methodologies. So keep in mind those three testing methods: FRACs, the DEXA TBS scoring, and the Hounsfield units off the CT score, which are opportunistic, so to speak. Okay, and they've all been shown to be very, very effective as far as diagnosing these things. Keep in mind the basic bone panel we talked about, the basic risk factors we talked about. Are they taking steroids? Okay, are they taking a tumor necrosis? Some papers say it causes osteoporosis, others don't. And the most recent thing that is the rage that probably 50% of the population is going to be on within the next 5 years are the GP1 blockers. There is a suspicion that they may cause osteoporosis, which would only make sense unless you continue to exercise heavily, because there is a tendency perhaps to get osteoporotic. So that's on. We'll report on that later on when some of the papers that I'm aware of come out in publication. So be a Sherlock Holmes. Don't just not investigate somebody that has a fracture when they fall and they break their wrist. If they have not had a DEXA scan and they're over 65, they should have had it already, and if they have the fracture, you should go ahead and get it, because you can justify that to the insurance company. These are preventive things we can do to prevent a fatal hip fracture, which results in hospitalization and carries a high mortality, not to mention the morbidity associated with that. And those are things that are potentially avoidable with a change in lifestyle that we talked about, simple vitamin D3 and calcium and medications, exercise, and this all slows the loss. And if they're over the thresholds we've talked about, they should be treated. So we'll talk more about these throughout all the sessions and kind of try to reinforce them, but these are the highlights of what I want you to take away from this particular lecture. Thank you.